This video presents examination of the abdomen, including inspection, auscultation, percussion and palpation of the abdominal wall, percussion and palpation of the liver, percussion and palpation of the spleen, and palpation of the right kidney and aorta. In the video, the examiner will assess a healthy patient. Keep in mind that other patients may have the same normal findings or may exhibit normal variations or abnormal findings. Before beginning the examination, let's review the structures of the abdomen. The abdominal wall extends from the rib cage above to the pelvis and inguinal ligaments below. The rectus abdominis muscles can be identified when a person raises both head and shoulders from a supine position. Palpation is easier lateral to these muscles. For descriptive purposes, the abdomen is divided by lines that cross at the umbilicus. These lines form the right upper, right lower, left upper, and left lower quadrants. The abdomen may also be divided into 9 areas. The 3 midline areas are the epigastric, umbilical, and hypogastric or suprapubic areas. The abdominal cavity extends up under the rib cage to the dome of the diaphragm. There lie much of the liver and stomach, and usually all of the spleen. The normal spleen is mostly posterior to the mid-axillary line. The kidneys lie posteriorly, partly protected by the ribs. The right kidney is slightly lower than the left. To assess for kidney tenderness, you should be able to identify the costovertebral angles. They lie below the 12th ribs, lateral to the vertebrae. The abdominal aorta, which may be palpable in the upper abdomen, bifurcates into the iliac arteries below the umbilicus. As the iliac arteries pass under the inguinal ligaments, they become the femoral arteries. The renal arteries branch off the aorta in the epigastric area. The intestines fill much of the abdomen. The sigmoid colon and portions of the transverse and descending colon may be palpable as tubular masses. Except for a pregnant uterus or a distended bladder, normal pelvic organs are not detectable through the abdominal wall.
Could you lay back now, please?
Before you examine the abdomen, make sure that the patient has emptied her bladder. Ask her to lie down and relax, and make her as comfortable as possible. Expose her lower chest and abdomen, but keep her genitalia covered.
Just going to take a look at your abdomen now.
Inspect the skin for scars, striae, dilated veins, or rashes. Inspect the symmetry and contour of the abdomen, and note any peristalsis, pulsations, or masses. Also observe the contour of the umbilicus and look for signs of inflammation or hernia.
Everything looks fine. Now let me take a listen.
Next, listen for bowel sounds by placing the diaphragm of the stethoscope gently on the right lower quadrant. Listen to their pitch, quality, and frequency. If the patient has hypertension, listen for bruits over the right renal artery, aorta, and left renal artery. If present, a bruit would sound like this. In a patient with hypertension, a bruit raises suspicion of renal artery stenosis, but most bruits have other causes. If you suspect arterial insufficiency in the legs, listen for bruits over the aorta, right iliac artery, and left iliac artery. Then identify and listen over the right femoral artery, and left femoral artery.
Good. Everything sounds fine there.
Next, lightly percuss the abdomen to assess the distribution of tympany and dullness. Tympany indicates gas in the stomach or intestine. Dullness suggests fluid or feces. Note any large area of dullness that might suggest a mass or enlarged organ.
Let me just adjust the gown here a bit.
Briefly percuss the lower anterior chest. On the right, liver dullness is usually present. On the left, you may hear the tympany of the gastric air bubble. Now palpate the abdomen, beginning gently and saving painful areas for last. With your fingers together, place your hand flat on the abdomen and press, using a light dipping motion. Moving smoothly, feel in all quadrants, identifying any tenderness or increased resistance to your hand.
Now, if you could, try to relax your abdomen a little bit more. Let it go real soft.
When resistance is present, try to relax the patient and palpate gently again.
Just let me know if anything's uncomfortable.
Then palpate more deeply in all four quadrants as you feel for any masses or tenderness. One hand on top of the other may make it easier to feel deeply. If you feel a structure that suggests a segment of colon, roll it under your fingers in one direction, then another, and try to assess its shape. Here, the sigmoid colon is palpable. Abdominal pain, tenderness, and involuntary muscular rigidity suggests peritoneal irritation.
I'd like you to try to cough and tell me where it hurts when you cough.
To localize it, ask the patient to cough and then show you where it hurts.
I'm going to try to...
Then try to localize the tenderness with one finger.
Right there.
If necessary, feel for rebound tenderness.
Now, I'm going to push down here, and I'm going to let go very quickly. And I want you to tell me whether it hurts more when I push down or when I let go.
Okay.
Press your fingers in firmly and slowly, then quickly withdraw them. Watch and listen for signs of pain.
It hurts more when you push down.
Unlike in this patient, pain induced or worsened by withdrawal is rebound tenderness and suggests peritoneal inflammation.
Shoulder.
Now percuss the span of liver dullness in the right midclavicular line. From an area of tympany well below the expected liver, percuss up to the lower border of liver dullness. Mark this spot.
Mark here.
Then percuss from lung resonance down the midclavicular line to the upper border of liver dullness. Mark this spot too. Measure the span of liver dullness between your two marks. Here it is about 7 centimeters.
About 7 centimeters. Now I'm going to try to feel the edge of your liver.
To palpate the liver, place your left hand behind the chest margin and your right hand lateral to the rectus abdominis muscles and well below the lower border of liver dullness. Press gently into the abdomen, and as the patient breathes deeply, try to feel for the liver edge as it moves down. If possible, let the liver slip under your finger pads as you feel its surface.
Try there again. Once more. Let it out. Take a real deep breath.
You often need to try again, using different pressures and moving your fingertips closer to the costal margin.
Once again, please.
The hooking technique may also be helpful. Standing to the right of the patient's chest, place the fingers of both hands below the border of liver dullness and press in and up toward the costal margin. Ask the patient to take a deep breath.
For one more time. All right. Out.
This liver is not palpable.
All right, that's fine.
To assess for tenderness when the liver is not palpable, place your left hand flat on the right lower rib cage and gently strike it with the ulnar surface of your right fist. Ask the patient to compare the sensation with a similar strike on the other side.
I'm going to examine the spleen, which is on the other side.
To assess the size of the spleen, percuss the left lower anterior chest wall in a lateral direction, noting the extent of tympany. If tympany is prominent laterally, spleen enlargement is unlikely. Next, check for a splenic percussion sign. Find the lowest interspace in the left anterior axillary line and percuss there. If tympany is heard, ask the patient to take a deep breath.
All right, now let it out.
As you continue to percuss in the same place. When spleen size is normal, tympany usually persists, and the sign is considered negative. An enlarged spleen is then very unlikely. When the spleen is enlarged, tympany often changes to dullness. This is a positive sign. This sign may be falsely positive, but it indicates careful palpation.
All right, I'm going to see now if I can feel the spleen.
Next, palpate the spleen. With your left hand, reach over and around the patient to support the left lower posterior rib cage and adjacent tissue. Place your right hand on the abdomen, low enough to detect a large spleen, and point your fingers toward the costal margin. When the patient takes a deep breath, try to feel the spleen as it comes down to meet your fingertips. Repeat several times, varying your hand position and moving it up gradually toward the costal margin.
Now, could you roll onto
Then ask the patient to turn onto her right side and try again. The spleen is not usually palpable. If you feel it, measure its distance in centimeters from the costal margin during inspiration.
Take a deep breath. Out. Once again. Out. All right, fine.
Normal kidneys are not often palpable, and enlargement is better detected by ultrasound. A right kidney, however, may be palpable in a thin, well-relaxed person. To feel it, return the patient to a supine position. Place your left hand below the right 12th rib posteriorly and press forward. Place your right hand in the right upper quadrant, lateral to the rectus muscles. Now ask the patient to take a deep breath. At the peak of inspiration, press your right hand firmly and deeply into the abdomen and try to capture the kidney between your hands. Ask the patient to breathe out and then stop breathing. Slowly release the pressure of your hands as you try to feel the kidney slide back into its expiratory position.
And I'm going to examine now for the aorta.
To assess the aorta, press firmly into the upper abdomen, slightly left of midline, and feel for its pulsations. In patients over 50, try to assess the width of the aorta. Pressing deeply with a hand on each side of it, try to estimate its width, normally 2.5 centimeters or less.
We're just about finished. Could you sit up, please?
Finally, assess for kidney tenderness when the patient sits up.
Check for tenderness.
Place the ball of your left hand on each costovertebral angle in turn and strike it with the ulnar surface of your fist. Normal kidneys are not tender. In summary, examination of the abdomen involves inspection, auscultation, percussion and palpation of the abdominal wall, percussion and palpation of the liver, percussion and palpation of the spleen, and palpation of the right kidney and aorta.